And Cody, we'll turn it over to you.
Great. Let me get everything set up. You guys seeing that correctly, Allie?
Yes, sir.
Great. Well, it's a pleasure to be with you all today on this blustery day up in Indiana or Lafayette area. It is snowing, but it's not sticking, thankfully, and we're not getting that much. But the holidays are amongst us. So thank you for joining us today, and thank you for listening in on this MACRA 101 presentation. For those of you who listened in earlier, back in late August, early September when we last held this, there is a lot of updated content in today's presentation as we are looking at the final rule that has come out. So first, I'd like to start with a little bit of a quote, that no one loves the messenger who brings bad news. So I just want to put a little disclaimer here that I did not write MACRA. I did not promote MACRA. I am just here to interpret and to share our understanding of MACRA to you and your facility and what it means as we move forward. But before we really dive into MACRA, I really briefly want to touch on two key concepts as we're moving forward and why we're doing what we're doing when it comes to MACRA. The first is really this emphasis that we're seeing really started around 2001 with David Kindig's initial report in the American Journal of Public Health of the concept of population health. And really looking at our outcomes, our mortality and our morbidity, and what plays a factor into driving what that is. For a while, we focused a lot on clinical care, and rightfully so. It's a very important science that we have. It's a very detailed science that we have. But further studies by researchers have found that only 20% of the outcomes in health that we're interested in, prolonging life and decreasing the presence of disability and disease, was made up by what we were focusing on in our clinical care. It was the other things in society that were really driving the factors of health, and this includes our environment, our social and economic factors, and our health behaviors. So just have that in the back of your mind as we're going through this presentation, of thinking that the hospital and the clinic really only accounts for about 20% of the outcomes that we're interested in, and MACRA will be judged against. Also, in early 2015, Medicare, Center for Medicare and Medicaid Services, CMS, came out with a report and goals saying we really want to transition our current fee-for-service system into a new system that's really driven on quality and driven on less resource utilization. Our goal was by 2016, so here in a few short weeks left, 30% of all payments coming out of the government through CMS will be based through an alternative payment model or an APM. And we'll get into exactly what that means towards the end of our presentation. 85% of the care that we're delivering are going to be linked to quality. So we're going to have that linkage. And only 15% are going to be the old school fee-for-service utilization-based payment. In 2 short years, though, we hope, and the goal and the target is 50% of all payments will be based on an alternative payment model, and 90% of all payments will have some sort of link to quality moving forward. So that takes me into MACRA 101. MACRA stands for the Medicare Access and Chip Reauthorization Act. I just absolutely love that the government uses an acronym with acronyms in it. So if you're thinking, what is CHIP? CHIP is the Children's Health Insurance Plan that President Clinton back in the 90s passed, and then Medicare, obviously, from 1965 under the leadership of President Kennedy. So I first want to pause. This is one of the first new slides. MACRA is not the ACA. We hear a lot of talk on the media, a lot of talk on the news, on Twitter, however you get your information, that the ACA is going to be repealed. House Speaker Ryan was on 60 Minutes on Sunday really discussing that. I've not watched the segment, but really discussing that. And I think some people are thinking, okay, ACA is going away, therefore I don't have to worry about MACRA. I really want to highlight here that MACRA is its own unique piece of legislation that was written by Congress, that was passed through Congress, passed through the House, the Senate, and signed by the President. So if the repeal of ACA does occur, and I'm not here to speculate on that, but if it does occur, that piece of legislation is in no way going to repeal MACRA. MACRA would have to be repealed itself. And we're not hearing any discussion of MACRA, and we'll get to in a second of why, of MACRA being repealed. I was at a conference earlier this fall and listened to an attorney that worked on the ACA and really highlighted this point, that this was the vision of the Obama administration, to have these unique pieces of legislation that would not all be in one basket of repeal. And here's why. MACRA is a bipartisan legislation, which in 2015, hearing the word bipartisan almost makes you think that I'm not speaking the truth. But House Rule 2, House Bill 2, was introduced to the House March of last year, 2015. It was heard in 6 committees. And in the House, 392 of the 435 representatives, so 37, did not vote for it. 392 did vote in favor of it, which was Democrats, Republicans, Independents, all shared. About 2.5 short weeks later, the Senate received the bill and voted on it. 92-8 voted for that, in favor of that. 92 of our 100 senators did vote in favor of that. Only one Indiana representative, the gentleman out of northern Indiana in the Gary area, I'm drawing a blank on his name, last name starts with a V, was the only one in Indiana that did not vote in favor of this. All of our Republicans and Democrats in both chambers did vote for it. And then the president received it, and he did sign it in law in about 2 days. So, this is the slide last time, but now there's some red over it. So the proposed rule came out Monday, May 9th. It's roughly 426 pages. They opened it up for comment June 27th, and they said, oh, you're going to get final rule in September of this year. I know we heard a lot of rumors about how many rules and comments that they got to that proposed rule, and that would be delayed. Now there's discussion, is it going to be delayed enough that we will hear after the election, or will we hear it before the election? And we really, those of us who are studying it very closely, really thought it would happen after the November election. But we were surprised yet again. The final rule was released Friday, October 14th. It is final rule with comments, so there's an opportunity still to make comments if you're not happy with the final rule. But the final rule went from the 500 pages that came out in May to about a 2,800-page document. So there's a lot of detail in there, and there's a lot of holes still yet to be filled in more rulemaking. So what are our goals of MACRA? Well, it's really 3 basic goals. And when I say basic, I mean that in the healthcare sense of basic. A lot more advanced than just 3 simple things. But it's to end the sustainable growth rate, SGR, formula for determining our Medicare payments for healthcare providers and services. Everyone recognized that the SGR was a broken system. It was not a good way to pay providers, regardless of which side of the aisle you sit. It was something that needed to be approved. So MACRA is the first stab at this to really ensure that we're working on this and getting rid of that. We want to make a new framework for rewarding healthcare providers for giving better care, not just more care. So we really wanted to do a deep dive into what is good quality healthcare and how do we incentivize our providers in order to deliver what we really believe is the best care possible. And then we really wanted to also try to simplify things. We wanted to try to combine our existing quality reporting programs into one new system. And they have done that, and we'll get into that in a minute, but really to simplify this so you have one reporting requirement per year. So like anything, we try to give a choice. When you work with a little kid and you want them to eat a vegetable, do you want peas or corn? You know that they're going to choose a vegetable, but you hope that they'll eat them a little more quickly, giving them a choice. And government, I think, try to use the same philosophy. So there's a lot on this slide that I want to work through. First off, I want to start off that MACRA affects Medicare Part B and the physician fee schedule from Part B, and that is it. Part A, C, and D are not a part of MACRA. Okay, so we're only focusing on Part B here. You have a choice. We can go left or right. We can go with MIPS, or we can go with an APM. APM is the one that you opt into. MIPS is the one that you're automatically enrolled into if you do not opt into an APM. So an option of not doing anything is not an option under MACRA as it stands right now. For 2017, it affects these 5 unique groups: physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. Those 5. In 2018, though, this is going to expand to affect respiratory therapists, occupational therapists, physical therapists, speech-language therapy. We're going to get into that in some other webinars, and we're going to discuss that here at the end. But really about 18 unique licensures that bill under Part B will have MACRA applied to their profession. You're saying, wait, I'm a low threshold provider. I normally don't have to participate in Medicare Part B programs. Maybe I was exempt from meaningful use. I was exempt from PQRS or one of those programs. There is an option that if you're a low volume threshold provider, and that means you bill less than $30,000 a year, provide care for less than 100 patients a year, you are a low volume threshold. So if you see 101 patients or you bill more than $30,000 a year, you're not exempt from MACRA. You are in that you do not meet the threshold. This is raised. It was 10,025 in the proposed rule. This has been raised for the final rule to 30,100. So the other area that you are exempt is if you are hiring a new provider into your practice who is fresh out of school or fresh into the practicing world, and it is their first year of billing Medicare Part B anywhere, not just at your facility, but anywhere, then they have a 1-year hiatus and break from MACRA before they are eligible for MACRA. Rural, a lot of questions handle how does this affect the rurals, because we have rural health clinics, we have unique different setups and designs of that. Any bill under the physician fee schedule, so Medicare Part B, are required unless you meet that minimum threshold. This includes those critical access hospitals who are billing under Method 1, and any eligible clinician who has assigned their Medicare Part B billing to a COF through Method 2 regulation. If you're an FQHC or an RHC, in those cost-based reimbursement settings, you are exempt from MACRA moving forward. Now, we are hearing discussions. I've been on a few webinars. CMS is trying to understand how do we apply the theories and the principles of MACRA to a cost-based reimbursement payment model. Once that is decided and determined, I really believe FQHCs and RHCs will be included. They're just exempt this 1 year due to the complexity that they present to themselves. So what's the timeline? Well, this is the old slide. The timeline really has not changed that much. There's a few tweaks to how you view this. But really this starts in a very few days. This starts here in about 3 weeks, less than 3 weeks, on January 1st, 2017. Reporting starts, we'll get into that, and then penalties and bonuses will start in 2019. So we'll pull this back up at the end, moving forward. So I'm talking a lot about MACRA. There's MIPS, there's APMs, but before we really do a deep dive into what each of those look like and how our physicians, our providers will be affected by that, I want to very briefly discuss some of the measurement development plans or the MDPs, because this is going on right now. There's a lot of information going on. How do we measure that? So, measurement. I'm an academic. I'm working on my PhD. It's a great philosophy debate that we like to have in academia. What is measurement? How do you measure things? What is quality of care? But now we really need to take away from that conversation and make it very practical. So a draft plan was posted by the government December 18th of 2015, so a little under a year ago. It was open for comment through the first 2 months of 2016 this year. And they received roughly 60 individual comments, 150 institutional comments. And the final measurement plan for 2017 was posted May 1st. This applies for MIPS and APMs. So, a couple things I really want to highlight looking at the key dates and how this works is they will revise and update as our scientific knowledge improves over the measurement of quality of health care. They will be updating the measurements that are used within the MIPS and the APM models. You can see here that in June of 2016, our call for measures end. November of 2016, our measures and final rule came out, starting in January 2017. We anticipate April of next year coming up that they will have a progress report of how we're doing. And in June, they will have an opening or closing of a 90-day call of updating those measurements. And in November, they'll come out with a report for January of 2018. And this cycle is going to go on and on and on. Currently, they have out for comment right now some measurements. So if you're interested, please let me know. I'm more than happy to share that information with you of what they're looking at, how they're looking at it. There's a lot of really smart minds working on this. The National Quality Forum, the Agency for Healthcare Research and Quality, PCOI, the Patient-Centered Outcome Research Institute, all those groups that we've always been going to for our measurements and not always related to the government are at the table in the discussions. So I really want to highlight here, there's 6 main categories of measurements, domains that we're looking at when we're talking about MACRA and MDPs. One is clinical care. We're looking at measuring and incorporating that patient preference and shared decision making. Looking at cross-cutting measures that may apply to more than one specialty. How do we simplify a very complex piece of legislation? How do we have focused measurements for our specialties that have clear gaps that we're working on improving? What a primary care doctor does is very different than what a urologist does in his office setting or her office setting. What are the outcomes of the care that we're delivering? We're not only looking at what care are we giving, but what are we getting for what we're giving? Safety. This goes back to the IOM Crossing Quality Chatham Report in 1999. We want to keep our patients safe. I just got back from the Institute for Healthcare Improvements Quality and Safety Forum that was held in Orlando last few days. Safety was at the #1 topmost discussion point of how do we keep our system safe moving forward. This looks at diagnostic accuracy. This looks at medication safety, drug classes. Care coordination. We're in a very team-based care. How is that information shared? Are we using technology to do that? Is telehealth something that we're using at the table to be able to share the information that we want to share? Patient and caregiver experience. Are the patients and their families feeling like they're engaged in their care? Are they being asked the key question that Marie Biziagno, what matters to them? Are they given and empowered? Population health and prevention. Are we developing or adapting outcome measures at a population level? We've really talked about this, and that's why I wanted to start with that population health framework. But how do we affect our town, our county, our community? Rural health facilities, I think we do this better than some because our community is where we live. We're not living in an urban center going to the suburban, so we have that disconnect. These are the towns that we live in. How do we do that? The Institute of Medicine, IOM, is having all these vital signs. How do we look at that? And that's being incorporated into this work as well. Are we detecting and preventing chronic diseases, the ones that are really bankrupting our healthcare system? And then lastly, they're also looking at affordable care. We've seen the studies. We know that there's waste in our system. How do we decrease the waste without affecting quality and still allowing joy in the workplace for our physicians? So that's the measurement piece. So we have to measure for MACRA, for MIPS, and for APMs. So let's start. Let's do a quick look at what is MIPS. What does that look like? So MIPS stands for the Merit-Based Incentive Payment System. And like I said earlier on in today's presentation, regardless of where you're going, you're in MIPS. You can opt out and go into an APM, but if not, you're in MIPS unless you meet that low-volume threshold. MIPS is a new program that combines part of the Physician Quality Reporting System, PQRS, the Value Modifier, VM, and the Medical Electronic Health Record, aka Meaningful Use, incentive programs into one singular program in which all eligible physicians will be measured on quality, meaningful use of certified EHR technologies, clinical practice improvement, and resource use. So we're taking 3 very massive programs, PQRS, meaningful use, and VM, combining it into MIPS for cohesive reporting across these 4 domains of quality, meaningful use, improvement, and resource use. Pause. Remember, MACRA is a Part B program. So Part A has value modifier, has meaningful use, has other quality reporting metrics. Those programs are not going away for Part A providers. This is a Part B program. So what a change. So 2017, the government came out in the final rule and modified very quickly how your MIPS scoring is going to occur in 2017 versus 2018 and beyond. 2018 beyond is what was proposed, it's what we've been thinking about. And really the major change is the removal of this gold column, the cost and resource use. So in 2017, your cost and resource use will not be a factor in your MIPS memberships. Quality, though, which was and will be 50% moving forward in 2018 beyond, will account for 60% in 2017. So the big chunk, 60%. Advancing care information, aka meaningful use, will make up a quarter, 2017 and beyond, of how much your measurement. And then clinical practice improvement will make up roughly 15% of that. Then in 2018, that quality, 10% of that quality will go down and go over to resource use. So we don't have to worry about, in this first year, resource use. So we have another year to be working on that and figuring out exactly what that means for our facilities moving forward. So, quality, 60% in 2017, 50% in 2018. What are we looking at? Well, these are some of the measurements we just discussed. Patient outcomes, appropriate use, safety, efficiency, patient experience, care coordination, things that our facilities are already striving towards, working on, being very well at, working on improving. But these are the measurements that will go into your quality. And we'll get into that a little bit later of exactly what's your numerator, what's your denominator, how do we track this. Care information, formerly the meaningful use program, makes up a quarter of your score next year and moving forward beyond. Are you protecting your patient health information? Are you using e-prescribing? Do you have a portal that your patients are using? Do you have coordination of care through patient engagement? Are you participating in your HAEs as health information exchanges, MIN, IRHA, the different ones around the state? Are you participating in public health and clinical data registries? How is that going? Are you doing all of that? If you have providers who said, I'm not on an EHR, I don't plan on going on an EHR, they are excluded then from MIPS of participating. That is a price of entry into MIPS. If they're not on an EHR, they're excluded, and we'll get into what that means. That it's not that they don't have to participate, that means they get the penalty. Clinical practice improvement. This makes up about 15% of that total score, 2017 beyond. And they really try to be as nice as possible and give you 90 things to choose from. If you're partnering with the GLPTN, the Great Lakes Practice Transformation Network, participating in that counts towards this category. It's an integral part of that. We work very closely with that team. This can include expanding your practice access, population health management. Are you including all that data? How are you coordinating your care? How are you engaging your beneficiaries? Do you have patient safety and practice assessments? Are you drilling? What's your emergency preparedness and response? CMS has really changed that in the last few months. What's that look like? Are we integrating behavior and mental health into the delivery of care? Again, this makes up 15% of your total practice. And then lastly, we have our cost or resource use. This is 10% starting in 2018. So we have a year. The previous three groups, I mentioned all these different reports. I've mentioned that you kind of get to choose that. We're going to go later at another webinar into what that really means. But that also means you have to report that information to the government above and beyond all the other things you're already reporting to the government. This is an additional reporting requirement. For cost or resource use, though, the government's the one who's paying the bill, so they have all that data already through your claims. So you have no additional reporting needed. It will be based on your claims data. So that is, if any good sign. The new thing in 2018 will not add to the reporting. The reporting will be what it is 2017 and moving forward. So, I said the program started in 2017. It starts in 3 short weeks. And that's the case. We really thought they might delay the launch of MACRA moving forward going on, but they did not. But they did say, we're going to give you 4 options to pick your own speed with how quickly you want to go into MACRA. So we're going to give you that choice, and we want you to think about that. So let's talk through what each of these choices mean as far as workflow for your facility and potential income and outcome. Well, your first option is here in the red. It's on the left. You can do absolutely nothing. You can say, I'm not going to participate. And that's your right. You absolutely can. But you're going to get the maximum payment negative adjustment possible for 2017. MACRA and MIPS is budget neutral. So what that means is for everyone who gets a penalty, for everyone who gets a bonus, there's an equal person getting a penalty. Maybe not a one-to-one, this hospital paying this hospital and that linkage, but there's roughly going to be $837 million in bonuses being paid out. Inversely, there's $837 million of penalties being paid into MACRA. So by not participating, by forgetting what you're doing, you're basically going to say, I'm going to take a 4% penalty on all Part B payments in 2018. So that is an option. Second option, you can do something. Submit something. And this is a graphic from CMS. I like how they have that. Just submit something. If you submit a minimum amount of 2017 data, for example, one quality measure and one improvement activity, you don't get a penalty, but you don't get a bonus. You just have no effect. You get another year to practice, improve, and to plan. But you have to submit those one quality metric and that one clinical practice improvement metric. If you're saying, well, I really want to see if I can get that bonus, I really want to strive for it, but I'm not ready to start in 3 weeks. Well, you can submit 90 days or a quarter worth of data for 2017. You may earn a neutral, I guarantee you'll earn a bonus payment, or a small positive payment adjustment. I want to highlight the word small, okay? If you say, I really want to go, I want to achieve the most possible at the table, you have to report for a full year all your data, like that was the original design, and then you're eligible for a moderate payment adjustment, or the maximum that they're willing to pay for the 2017 reporting year, which we paid out in 2019. Okay? If you participate in the partial or the full, you are protected. You isolate yourself from having a penalty. You will only receive that penalty if you do nothing at all for this first year. I'll leave that slide out there for a second. So just be thinking about that. If you don't know what you're doing yet, you don't know how this is going to work, there are options to slowly ease into this. So what's the timeline for this first reporting year? Like I said, first reporting period opens January 1st, 2017 and goes through December 31st of 2017. During 2017, you record that quality data and how you use technology. You're going to advance APM, how that fits in. We'll get into what that really means. And then in the next first quarter of 2018, so about a year from now, a year and a few months from now, you will have 90 days to report in all your data through technology. You can't send in a piece of paper. You got to do it electronically. The remainder of that year, CMS will do all the number crunching, will do all the analysis, will interpret all your data, everything you've given them, and they will assign to you your bonus or your penalty. That bonus or penalty will be an adjustment, positive or negative, starting January 1st, 2019 on all Part B payments. Okay? Well, I'll highlight that. This is on all Part B payments in 2019. So by doing nothing in 2017 and opting for that negative 4% penalty, that financially will not affect you till 2019. But that means if you wait till 2019 when the financial penalties start, you have 2 years where you did nothing that you will be dinged until you can start improving on that. So what's the timeline moving forward past that? Well, 2017 reports into 2018. 2019 has a positive or negative 4%. 2018, we are not foreseeing any pick your own pace. You're reporting a full year's worth of data from everything that we're seeing, subject to change in our current new administration. But 2018, you report all year. You report in by that end of first quarter 2019, 2020. Penalty or bonus is 5%. 2019 to 21 is 7%. Then 2020 to 2022 will be the maximum that we get to with this program, which is a positive or negative 9% bonus or penalty. Okay? So the first year you got that 4%, you may be saying, you know what, 4%, I can write that off on the books and move forward and live with that. But do know this is going to stair step over the next 4 cycles to 9%. And there's going to be a total of 6 cycles based on the legislation. This only goes through 2022, but 2023 and 2024 will also be that 9% adjustment. So I'll leave that up for a second. So if you're with other people, you can kind of discuss what that might mean and how to prepare for this, how to move forward from this. While you're doing that discussion, I'll also add IRHA is fortunate. We have several highly qualified board members, 2 of which work with 2 of the 4 MCOs that will be in the state for Medicaid. And they basically came to us, we had a discussion with our board about MACRA and said, We have a team following how MACRA goes, and if it goes well, we are looking at potentially how can it be expanded into our offerings. So right now it's a Medicare program, but we think it may expand if there's early success by Medicare. I'll also highlight Monday this week. I was saying, next to a representative from CMS. This is an off-the-record conversation, just kind of small chat, and I said, "Hey, what do you think of MACRA?" And she says, "It's not going anywhere from everything that we can see. ACA is going to get a lot of breath, but MACRA is here. It's moving forward, and it's bipartisan support. It's budget neutral, so it's not affecting the deficit." So you're going, okay, I'm in MIPS. I have no option now that, oh, sorry, I did forget one thing. I want to comment on this slide. I do apologize for this. If you're going, I'm a low-volume threshold provider. I have less than 100 patients. I have less than $30,000 in claims. You do not know that you're a low-volume threshold provider until after the reporting period is over. So that means if, by chance, you hit 104 patients and you thought you were going to be around 95 and you hit that 104, you're now incorporated into MACRA after the opportunity to report. So if you're on that bubble, if you're on that threshold, please be very careful and cognizant of where you're at on that, because you'll find out how the government classifies you when it's too late to change your activities. So if you're on that threshold, I'd encourage you to still participate, at least report that one piece moving forward, so you're at least neutral for 2019 and kind of can see moving forward. So you're going, okay, I don't like that MIPS. It's a lot of work. I'm not prepared as a facility. My physicians, my providers aren't ready for that. Well, we give you an option. You can be in an advanced alternative payment model, an APM. What these are is it requires your providers, your physicians, to bear financial risk. This is transitioning more and more away from a fee-for-service or a fee-for-service tied to quality payment model to that 30 and 50% that we saw in the graphic at the beginning of the presentation to what, frankly, is a capitation-style payment model. You still will have your base payments based on quality measures, comparable to those that you'd be reporting in MIPS. You're still required to use a qualifying EHR. So you still have to participate in those types of programs. What are examples of APMs? What are some of the things that you can do? Well, you can be in the Comprehensive Primary Care Plus Initiative, CPC Plus Initiative. You can be in the End-Stage Renal Disease Care Program. You can be in a Bundled Payment Model Program. You can be in one of 3 different kinds of ACOs, the Next-Gen ACO or a Track 2 or Track 3 Medicare Shared Savings. Or you can be in the Oncology Care Model. 25% of all your patients must be in this model to qualify as a provider for an APM. So if you have a few who are in a bundled payment because you do knee or joint work, great. But if it's only about 5% of your population, that you're still in MIPS. That 5% is good. Not good enough. Currently, there's only one major health system in the state of Indiana, or in the whole state of Indiana, that will do that, or that qualifies currently as an APM, and that is the Deaconess ACO, their Track 2 ACO down in Evansville, Indiana. Everyone else is not currently qualifying. That's something that we can discuss moving forward, if that's something that you would like to discuss more about during our Q&A section. But there's something that you could qualify for. So if you say, okay, I'll go into the APM, well, they will give you a 5% incentive payment. You will be excluded from MIPS, and you will not have a penalty payment risk. So you do not have to do that. So that's moving forward as well. Or you can go into MIPS. This is the graphic I showed at the beginning where you get a 4% bonus or penalty starting in 2019, and that's amplified to 9% by the end of the year. So we recognize that what we just did in about 30 minutes, if we kept going on a lot longer, everyone eyes are glazed over. There's a lot of detail here. There's a lot of information here. There's a lot of strategy that needs to be determined both at the leadership level and at the provider level. One of the discussion points is how do you report? You can report individual providers, and they are amongst themselves, or you can report as a group, and then everyone would get the same adjustment within that group. So there needs to be looking at data and discussion over what's best for your facility. And also this is adding a new kind of competition amongst providers because you don't want to be paying the penalty for your direct competition. So here at Indiana Rural Health Association, we have a lot of support that we're ready to offer. We're doing this MACRA 101. It's being recorded. It's going to go on our YouTube channel probably by the end of next week, if not sooner. You're more than welcome to have access to that to watch. But we're going to do one like this, a 201, a 301, and a 401 in January, February, and March, where we do a more deep dive into what are some of the quality measures, how are some of the reporting done, what does that look like, to kind of walk through some of that with your facility as well. We've also done facility support, where we come on site to your facility. We offer, I've done this presentation for providers as well as administration, kind of help develop plans and support that. IRHA, though, is very fortunate. We get to work with a lot of great colleagues, great support, and we have a lot of great resources here in the great state of Indiana. So there is the Great Lakes Practice Transformation Network, or the GLPTN. They're currently full, so if you're not participating with them, you are not, they're full. They have a waiting list you can get on. If you are participating with them, that is absolutely great. There's nothing that we're doing as direct competition with them. We talk with them at least once a week to kind of say, here's the concerns we're hearing, what can we do to help? Here are the concerns they're hearing, and what can they do to help? And then QSource as well, who is the TA for the state of Indiana for Medicaid, or Medicare, excuse me, Don and his team. Again, we talk with them very heavily as well. So again, we are not here, none of us are competing. We are working at this together. And there's times where you'll email me a question, I'll say, I don't know, but I know the GLPTN people know, and I'll refer you to them, or QSource, or they'll refer you to me. So don't hesitate. All we want you to do is get the help that you need to reach out to whoever you can reach out to the quickest and the easiest as we're going into this holiday season. So with that, I'll open it up for questions. I've seen some come into the chat that I'll get to here in a second. My contact information is here, my phone number, that's my desk line, and my email. If there's anything that we can do, any information that we can provide, please don't hesitate to reach out to me. I will let you know when you do email me. You will most likely get out of office. I am on the road every day but this afternoon through Tuesday. So if I don't get right back to you, I will respond to you Wednesday or Thursday when I do get back to the office as well. So with that, I will open it up for questions. Hopefully this is helpful and informative, and look forward to a very rich conversation.
And while Cody looks at those questions, I'm going to share a quick link with everybody. This is the link in the chat window you should see now to our post presentation evaluation. This is another thing that's extremely important for us to keep having these free programs for you. So if you wouldn't mind, when we're done with the presentation today, just follow that link, take the survey. It's a very quick 2 to 3 minute survey max. We really appreciate your feedback.
So the first question that I have received in my chat window, and please feel free to chat in questions as they come up. And I'm not sure who this is from, but do you know how reporting requirements of meaningful use or PQRS will change under MIPS? Do eligible providers, EPs under Medicare, still report through CMS's enrichment's website, or has that totally been replaced in 2017? I can't say, and I will copy this, so whoever sent in this question, I'm feeling you sent directly to Allie. So Allie, please get a name for me. We will follow up with you. That is one of the things that I want to make sure to reach out, like I said, to QSource and ask them, because they are really the experts, and I see those from Memorial. So we'll get you an answer for that. It will be changing. It will look different since it is one continuous reporting system. But I'm not exactly sure on the mechanism. So we'll get that information. I'll share that with you in the near future. Next question, will the slides be available? They will be available on our YouTube channel, so you're more than welcome to go there, and you should be able to access the slides from our YouTube channel as well. Question is, what is the bare minimum number of performance measurements do we need? Is there an example of potential measurements? Yes, this is from Tom. This is something that we're going to go into in 201 is that. It really depends, and I hate to answer a question like that. It depends on if you're going the full or the partial or the minimum reporting mechanism. So if you're doing the minimum, it's 1. If you're doing the partial, it's 3 of each. And if you're doing the full, it's 6 of each. So we're going to do a deep dive. What does that look like? How does that work? I really encourage you, I'm going to go back here on a few slides. Sorry if I'm making anyone dizzy. But if you go to this website, qpp.cms.gov, you are able to go in there. There's a whole measurement site where it's very interactive, or as interactive as a governmental quality reporting website can be, where you can go in and say, okay, for quality, I'm this specialist, what are my measurement options? Then it gives you narrative about those measurements. There's a lot of other resources that we'll be sharing in January. If you like information on them beforehand, let me know. I'm more than happy to share that. That CMS has put out, not to scare anyone, but just giving an idea of the breadth of information that CMS is producing around this. They came out with a singular document that you can download that has all of the measurement information in it. It's a PDF. It's 257 megabytes. It's a quarter of a gigabyte. Is the singular PDF. So there's a massive amount of information out there that I'm more than happy to share with you, and that we'll try to synchronize a little better in January when we have that lunch and learn. Like I said, if there's anything that we can do to be helpful, please don't hesitate to reach out to us, as well as reference our upcoming resources. And all of the lunch and learns that we're going to be doing in the first quarter of 2017 will be recorded on our YouTube channel. So if you can't make that specific session, there'll be an opportunity to see it afterwards. What is the day of the next presentation? That is a great question. We do not have that date at this time. It will be in January, most likely the second or third week on a Tuesday, Wednesday, Thursday from noon to 1. But I will make sure, Tom, and anyone else, I will make a note. And as soon as that date is confirmed, I will send you a meeting invite to make sure you know that.
And you can all always go to the Indiana Rural Health Association's website, which is just indianaruralhealth.org, and check the events page. That's where we keep a running list of our upcoming lunch and learns.
So the next questions are the limited requirements for behavioral health provider. The limited requirements, and I'll go ahead and flip back here. Sorry if I'm making anyone dizzy. This is the minimum requirement, limited requirements for all providers regardless of specialty or area of expertise. So if it's $30,000 a Part B and less than 100 visits for any of those 5 specialties, there are no modifications of that for other per specialty.
Okay, well, we'll leave the line on for just a moment longer. If you haven't used the chat function to let me know what facility you're attending on behalf of, please do. Again, you can find the chat function by hovering your mouse at the bottom of the screen, in the middle of the page. You should see it. We do ask that you let us know where you're attending from, and also we ask that you follow that survey link that I provided to you earlier. I will try to have this presentation loaded to YouTube sometime this afternoon. You can find us by searching on YouTube for Indiana Rural Health Association, MACRA, anything like that, and we will have it up there for you. We've got our own channel, so we should be pretty easy to find. I just really appreciate everybody coming out today, and Cody giving us his time and information. Again, we'll go ahead and leave the line open for just a few more moments if anybody has any other questions. But for the rest of you, have a great day.
Yes, and we do have one more question that just came in. It says that I mentioned that if you're not on an EHR that you're excluded from MIPS, does that mean you take the penalty? And yes, not having an EHR is a requirement of participation, and without that, meeting that requirement, you're not allowed to further participate and therefore get the penalty. So again, we can share more information on that, and the GLPTN folks are really experts around that among our team. So happy to make a connection there too if needed.